Okay, well, now I will formally welcome everyone to CAIEP's Fall 2024 Interprofessional Student Showcase. This year, we appreciate that students, prospective students, faculty, staff, and UNE leadership take the time to help us celebrate the interprofessional work that all of our students do, and you'll be delighted at what you'll be seeing. This fall showcase highlights two programs. The first one is the Interprofessional Team Immersion, or what we call IPTE. And the second one is COM's Adapting Public Health Problem-Solving Paradigm in Interprofessional Team Training, or shortly FIT. And that is mentored by Dr. Ling Cao and by Dr. Kin Lee, who happens to be our very first interprofessional distinguished faculty who spent the semester with us and learned all about interprofessional education and practice. One thing I'm going to mention, you'll notice that FIT and IPTE are a little different from one another. The FIT students actually create their patient, and the IPTE students are assigned a patient. So you'll see a little bit of a difference in both. But both are longitudinal learning experiences that bring together interprofessional teams, and the students work together to problem solve the complex health problems that are presented to them. So that's what you will be seeing today. I will also want to mention that students who participate in the showcase often get to go and present their work at conferences, and it's something that is a great incentive to be thinking about putting something together for the spring showcase or encouraging your students to do so as well. This year we had several students present at various places. The first one was the American Physical Therapy Association that will be coming up in February in Houston. And you'll see the two topics that the student posters will be presenting. So we encourage you to get students and have students participate in the actual IPTE and FIT programs, but also to be thinking about their future in presenting at national and international conferences. So it is now my distinct pleasure to present Dean John Vitale, who will be giving remarks today. He is the new dean, sort of new, right? Sort of newish dean of the Westbrook College of Health Professions. And we like to think of him as the newest member of our esteemed collection of interprofessional allies. Welcome, John. And Dr. Vitale joins us with over 15 years of leadership experience in higher education, including at Rosalind Franklin University, our colleagues here, and where he was an avid supporter of interprofessional education and practice. We are so delighted to have you here, Dr. Vitale, and we would love to hear your remarks.
Great. Thank you so much, Shelley. And welcome and thank you to all of you who are joining us today. This IP showcase is really the culmination of the work of interprofessional teams of students, faculty, and professional staff from both of our universities here at UNE and at Rosalind Franklin. And just a quick shout out to all my friends at Rosalind Franklin, where I spent the first 18 years of my academic career. So it's very nice to see some of your faces on the screen here today. UNE hosted the inaugural version of this IP showcase on September 14th in 2018. And in the intervening years since then, the showcase has expanded to involve more and more members of our UNE community and expanded to include our close friends at Rosalind Franklin University, as well as expanding to include dozens of different clinical programs, which are represented here today. None of this would have been possible without the passion and dedication of Shelley Cohen-Conrad. And I'd like to take a moment just to recognize Shelley. As many of you know, Shelley will be retiring at the end of this calendar year. And one mark of a successful leader is how well the groups they have led hold up after the leader is no longer there. And here at the University of New England, our Center for the Advancement of Interprofessional Education and Practice is very strong, and IP continues to be part of the mission and is involved in everything we do here at UNE, similar to our friends at RFU. It's integrated into our strategic plan and is truly part of our DNA. And we wouldn't be where we are today without all of the hard work and dedication that Shelley has brought to advancing interprofessional education, not only here at UNE, but nationwide. Today, we're going to be highlighting our students, though, and true to the original interprofessional model proposed by Demore and Odson, students are at the center of interprofessional education and what we're doing here. And we're going to hear from students in the course of their presentations who are demonstrating their commitment to collaborative care and to interprofessional education more generally. We're so excited to have all these students sharing their work with us today as they start their journeys in becoming strong, productive, collaborative members of the interprofessional healthcare. So really, thank you for this opportunity to address all of you. And I really look forward to hearing the showcase presentations from all of our students. Thank you.
Thank you, Dean Vitale. I also want to, my name's Chris Hall. I'm the program manager for the center, and thanks also to Shelley for her years of service, and we hope to be able to carry on. The thing I want to say to everyone presenting today is congratulations for getting to this point and for successfully managing your team experiences. And you are eligible to apply for the Interprofessional Honors Distinction. This is sort of the culmination of that application process. And so please don't leave that on the table. Make sure you get your applications in. To show prospective employers that you have understanding of IPE, and maybe you have some good stories to tell about how you've worked together with other students as a team. Now for the fun part, the navigation. We have 3 tracks today for you with presentations spread across those tracks, loosely organized by roles and responsibilities in track 1, teamwork in track 2, and communication in track 3. You'll be free to move about however you like. So if you've got friends presenting in track 1 for some part of it and in track 3 for other parts, you can move. There's a minute built in between each presentation to give you the time to do that. If you have folks watching on the live stream, you can see that with the yellow aspects in the program here, the live stream will move through the presentations at each break, so that each breakout room will have a chance to have their moment in the sun. So when the breakout rooms open, some of you will be automatically sorted and others of you will have to navigate, and we'll stay here. I'll be here in the main room to help you navigate if you have any questions. But have a really great time. Make sure to ask good questions and take a moment to really reflect on what your experience was like. This will sort of be maybe the last time you're all together as a team, and really celebrate the relationships that you built during that time. So Lee, I think you could go ahead and open the breakout rooms now. And if you're a track proctor, don't forget to press record the minute you get there. Thanks everyone, and I hope you have a great holiday.
We are going to start with the Healing Hive.
Hi, we are the Healing Hive from the IPD program.
Meet our team. We were made up of faculty facilitator Dr. Lee, peer facilitators Safon and Madison, Catherine, a DO student, Christopher, an MD student, Linnea, our PA student, Alicia, dietetic student, and Sarah, our dental medicine student. We decided on the Healing Hive because together we're greater than the sum of our parts, and the healthcare we delivered to this family was sweeter than honey.
In our case, we had Charlotte Soto. She was a 6-year-old female. She had worsening asthma with increasing cough and fatigue. She had a recent move which was causing stress and a recent ER visit. At home, she had medication side effects that were yellowing her teeth and limited nutrition intake. At school, she was unable to keep up with her peers on the playground, and she also had poor academic performance. And her family was accused of neglect by school faculty, and they were overwhelmed, stressed, and anxious about their daughter's health.
Overall, we had just a big aha moment that working as an interprofessional team was super awesome. Each profession brought in a unique perspective to the case. We immediately started pulling out aspects that we all wanted to tackle. Via these telehealth visits, we were also able to just pass along questions that we couldn't answer, didn't have the knowledge to. So anything about dental medicine, I could immediately just pass on to Sarah.
An IP team creates a supportive environment that reduces the stress and pressure on one provider alone by spreading the health knowledge. It decreases provider burnout and increases employee satisfaction. Additionally, it was more convenient for the family to meet over virtually, as they were in the comfort of their own home and didn't have to find a babysitter or spend gas money or transport a sick child to the hospital.
An interprofessional team also allows for time effective and streamlined visits. So it's nice having all the professions there on standby, easy and convenient to get their opinions.
And overall, we just think that working as an interprofessional team improves patient outcomes. They only had to tell their story once, and we were able to initiate a lot of really excellent care. As a PA student, I really focused on medications. We deprescribed and really streamlined the medications for this patient, hopefully improve her symptoms.
Parents were concerned about the lack of nutrition that Charlotte was receiving. She was pretty much only eating mashed potatoes. We recommended soft foods while her mouth was healing, in addition to meal replacement supplement drinks. We also discussed the risk benefits of over-the-counter supplements and discontinued duplicates that were present in her multivitamin.
And on the dental medicine side, we wanted to monitor signs of recurrent oral thrush, which was caused by her asthma, and then suggestions for regular dental checkups, as well as looking at the medication related tooth discretion.
And then just as a whole team, we were able to address the family at large. We offered mental health resources, referrals for allergy testing, and just general support groups too. So we were able to address the health at large. Thanks so much for listening to us.
Thank you.
Thank you.
Well, thank you so much for that. It's a very interesting way to see how everybody's working together on this particular case. Are there any questions for the group? If not, I do. Go ahead.
Sorry, Sarah. I have one, of course. Thank you to the group for sharing your IPTI experience. I was curious, given all the complexities with this case, how did you and your team go about not overwhelming this client and her family?
I think part of it was prioritizing like what their main concerns were and kind of just taking it one step at a time. We also met more than once, so we were able to kind of get the groundwork for the first meeting and then kind of tailor, like each of us kind of made our own plan on how to tackle each topic. So like we were able to kind of plan ahead of time, I guess, and then maybe simplify our recommendations. Would you add to that, Linnea?
I have an additional question before. Linnea, are you available?
Yeah, sorry. I think my Zoom just glitched out for a moment.
Do you have anything to add?
I only heard the first part of Alicia's comment, but I would stress, yeah, we did have a little time in our pre and debriefs to talk. And then I think one thing that we were able to do is each person on our team tackled a different part of the problem. So I think it was really helpful for me to discuss medications, for example, patient education, answered all their questions on that, and then we would move it along to the next person and discuss something else. And I think that was helpful for the family.
Very nice. I have a question. I wonder how the team came to form as a team. How was that process for everyone? Was it an easy process? Was it confusing? How did it work out?
I think that we all actually had to describe what our role would be to each other. We weren't super familiar with like everyone's sort of wheelhouse. So we actually took time to get to know like strengths of each other, maybe weaknesses. We didn't have a pharmacist on the team. We did have like a mentor who was a pharmacist and who offered to supply us with some resources. But Linnea actually had to, she felt comfortable, and maybe you want to speak to this, Linnea, you were the most comfortable in addressing pharmaceutical problems and maybe the most knowledgeable in that area. But I think a big piece for us was just discussing what each of us were comfortable doing. And if we didn't know the answer, to a question that we were asked, we were sure to comfort the patient and say, you know what, we're not really sure. We're going to do some research and we'll get back to you.
Yeah, I
Nice.
agree with all of that. And I think we had a really lovely group. So we just sort of got to chatting and things worked themselves out pretty quickly.
And I think I would add too, like all of us were pretty okay with jumping in to take turns with taking notes or recording. Like we kind of all just took turns doing these supportive roles during the exercises.
That's excellent. That's what's supposed to happen. Thank you so much. We're going to move on to our next presentation from the co-lobsterators, health and wellness in the special ventilation unit.
Hi everyone, for today's presentation, Ashley and I will be discussing the overarching themes from our respective Fall 2024 IPTE experience. We chose to focus on the importance of collaboration that we can all be a part of as healthcare professionals.
Hi, my name is Ashley Parkinson. I'm a first-year student in the UNE MS Applied Nutrition program with a focus on dietetics. I was part of the co-lobsterators, which was Team 1.
And my name is Janine M. Tran, and similar to Ashley, I'm a first year in the same program, and I was part of the Health and Wellness Special Ventilation Unit Team, or Team 4.
You can see on the slide that our teams consisted of students from many different healthcare professions. We also want to take a moment to acknowledge our faculty and student mentors who helped us with our case study, and also our faculty sponsor, Professor Brianna Fortin. Each of these images are great examples of how collaborative efforts work together to accomplish the best outcomes. From construction crews and machines to the ecosystems in the coral reef to a symphony and a conductor, they all need elements of everything involved to perform at their best. Healthcare is the same way. We all can take better care of patients when we collaborate with other healthcare professionals.
With that said, our team's objective was to work collaboratively as interprofessionals in our respective healthcare occupations, and to make sure that each member in our team was able to contribute their areas of expertise when assisting the patient.
My team did a great job at using their different leadership and non-maleficent skills to help the patient get their medications refined, to get the family connected with community and insurance resources, and to provide education to help them meet their nutritional needs.
My team leveraged soft skills such as empathy and active listening to make the patient feel seen, heard, and understood before providing technical skills specific to our disciplines. We were intentional in having the patient lead the conversation, acknowledge what the patient is already doing well, and offered clinical recommendations and community resources where appropriate.
Our teams were able to reflect in our final debriefings about ways we could have improved our collaboration and helped the patient better. There was a member on my team that wasn't sure how she fit into the case study with her skills. She shared that she could have stepped in more and realized she needed more confidence than what she was able to bring to the table. It was a great reminder for all of us that we each have something important to bring.
For our team, we received the feedback of only focusing on 1 to 2 recommendations per consult and build time to pause and ask open-ended questions, such as, how does that sound? Or do you think that's feasible? This is to better assess the patient's understanding and the feasibility of our recommendations.
My team and I learned that by slowing down our approach and understanding that more information can be shared in follow-up meetings through other team resources and through educational materials, that we can help the patient feel seen and understood and continue to be assisted at a pace that is comfortable to them.
The simulation helped us recognize the limitations of our scope of practice and the importance of creating a supportive environment where our recommendations could be realistically applied.
We wanted to give a big thank you to the faculty, student mentors, actors, and facilitators who helped support us and grow through this experience. And a big thank you to everyone for watching our presentation. We look forward to your feedback and questions.
Thank you so much. That was really wonderful. It's nice to see two teams working together. Are there questions for this groups?
This is Maria Manitou. I have a question. First, the slides are beautiful. They're very well organized, and the material and content is very clear. What did you use to create the slides presentation?
Thank you so much. That's a very nice compliment. I'm a Mac user, so I use Keynote. That's my preferred. Thank you.
I have a question. What kind of community resources did you recommend for this family? I think that's something that we also did not have a social worker on our team, so it was kind of something we had to do some research into. So I'm curious to hear what you came up with.
Do you want me to go first, Janine? Okay, so for ours, we recommended the library. They had a hard time making friends, and getting their kids
to get involved with friendships as well. And they were just really struggling with this new community that they were a part of. So the library has a lot of great resources for local things that they can be a part of. There's local co-ops. We also recommended being part of the WIC program, because the WIC program also has a lot of affiliations and partnerships with local organizations that they know can help, whether it's for diapers or vitamins or other situations like that. Being part of a Head Start program could also get their son, that was 3, that was younger than the daughter, involved in something and get the parents active and involved. WIC also can offer transportation services if needed sometimes. It just depends on the area. And that was one of their struggles as well. And I think those were the top ones that we offered. I'm sure that my group that I came from is actually presenting in this breakout room too, so I'm sure that they'll be able to answer more of those questions in their presentation, because we had amazing people that had resources. We had public health and we had occupational therapy. We had a lot of people that could bring a lot to the table, but those were pretty much the big ones.
I think for our group, the highlight was the insurance piece. They really wanted to streamline the care. And so we focused more on Maine Care, which is the Medicare, I guess, alignment for in Maine. And so getting them plugged into that insurance, which would open up eligibility for WIC, the National School Lunch Program, and also we recommended Head Start as well, but getting them into that main insurance system first to open up all that other eligibility was one of the ways that we tackled that. And we also recognized that the husband was part of the Army, so we talked a little bit about Military One, which is also a similar insurance benefits for people who have served. And that helps with housing repairs, daycare, transportation, even physical therapy that the husband might need. So in addition to what Ashley was saying, I think the insurance piece was really something that we had to research on, just to streamline the care after the consultation. How do we make sure that they get the information in one way rather than in scattered different ways? And in plugging them into that insurance system, we also help them get paired with a case manager who will just have an overarching understanding of the family's needs outside of the clinical lens.
That sounds like for both teams, it was a very comprehensive approach. That's amazing, quite admirable. Are there any big lessons quickly that you will take with you into your future clinical practice?
Yes, definitely. I think the feedback that we received, there was quite a few information that was shared with the family. I do recognize that that's a quick thing that I can implement when I'm educating a patient or a client, just to pause and say, how does that sound? Do you have any questions? In the middle, as opposed to waiting all the way at the end. I had said so many things and they don't even know what they're confused about. So that's definitely something I took close to heart and hopefully could do better once I practice as a professional.
I'm going to dovetail right off what Janine said, 100%. Our actress shared a quote that I just loved, and it's still with me, but she said in her acting class, her coach said, one of the best things to remember is a little proverb saying, we don't have much time, so we must go slow. And I think that's exactly what Janine's saying, quality versus quantity, how much you can take care of others. So, yeah.
All good lessons. Thank you so much.
This case is an interprofessional approach to anxiety and depression, presented by Benjamin, Dominique, Ezra, and John. Jeanette Doe is a 30-year-old Hispanic female living in a suburban area of El Paso, Texas, suffering from chronic anxiety disorder. The patient reported experiencing increased anxiety over the past 6 months, characterized by persistent worry, restlessness, and difficulty concentrating. These symptoms have since escalated, having lost her job due to the COVID-19 pandemic, leading to significant distress and impacting her daily function. Mrs. Doe was previously diagnosed with anxiety disorder, treated with sertraline, which has recently been increased in dose, in addition to generalized depression, hypertension, and mild asthma. She does not have any other past medical history. Her pertinent social history includes a monogamous relationship with her partner of 5 years, who currently works long hours in construction and provides for them both and their dog. They are currently uninsured. She is generally a healthy eater but does skip meals when anxious. She rarely exercises and prefers yoga but has not been able to attend classes recently, and she experiences frequent insomnia. Ms. Doe consumes 2 to 3 cups of coffee daily and drinks alcohol socially, increasing when stressed. She does not use nicotine or other illicit substances. In terms of family history, Mrs. Doe has a brother with asthma, a mother with anxiety and depression, a father with hypertension and alcohol use disorder, a parent also in her paternal grandmother, and a maternal grandmother with Alzheimer's disease. Our patient is currently unemployed and is relying on her husband's income. And in terms of support system, it is limited outside of her husband. She does have a few friends in the neighborhood, but she does feel isolated. She is actively looking for employment and does not have any community centers nearby that offer free mental health resources, which is something that she desperately needs.
Now that we've covered Jeanette's background, let's highlight some of the challenges she's facing to create meaningful interventions. Jeanette is a Hispanic woman living in El Paso. She recently lost her job, is uninsured, relying on her spouse's limited income. She's isolated from family across the border. She faces mental health struggles impacted by both social and financial loss. Living in a health professional shortage area limits her healthcare access for her medical disorders, while cultural stigma around mental health, reinforced by institutional barriers and coped with maladaptive behaviors such as drinking, makes her hesitant to seek help. According to NAMI, nationally, only 35.1% of Hispanic adults receive mental health treatment, increasing risk for people like Jeanette. With improved mental health resources and a supportive community, Janet could better manage her challenges. In this diagram, we've highlighted in red factors that worsen Jeanette's presentation. For example, under environment, we have the job market, which El Paso is known for service, retail, warehouse, trucking, and call centers, which aren't really in Jeanette's background of psychology. And for family, we see that she's inherited some of the past medical history that was reported by her family members.
Some of the resources that we found for Janet were identifying different community sources where she could seek career training and advice, joining a religious group to help her serve others and find solutions to her own problems in that process. Volunteering at a homeless shelter would help her build resilience and use her degree to help others as well. Enrolling in a self-reliance class would help her develop financial skills that would help her and her husband. We also found a low-cost telehealth therapy counseling service that would benefit her as well. We also thought, her family is not here, and maybe a trip to her family would benefit in the next slide, flight to Mexico, as well as some support groups that we found that will help her go through a course and be able to develop some more mental resilience and some strength emotionally as well.
We appreciate your attention to our case and can now take questions.
Hello, everyone listening. This is our presentation poster, Diverse Healthcare Perspectives on Childhood Asthma. These are our respective professions and our names.
Hi, I'm Sharonda Dubose, and I'm with Public Health.
My name is Kyla Gallup, and I'm with Physical Therapy.
My name's Sophia LaFrance, and I'm with Osteopathic Medicine.
My name is Mohammed Chick, and I'm with Occupational Therapy.
Hi, I'm Sydney Tews, and I'm with the Physician Assistant Program.
So this is our case right here. We have Charlotte Soto, who's a 6-year-old experiencing asthma symptoms, and her family is having quite of a challenge with her medications and managing her symptoms of asthma. This is the case overview. As you can see, the mother and father, she has siblings as well, and many medications which we have gone over as a group to discuss managing those medications. And the previous care right there, parents, the main one is the parents are feeling judged by the school system and are frustrated with previous medical care.
As a public health student, my goal was to help prevent future health issues for Charlotte and her family. I helped connect Charlotte and her family with dental and pediatric care, as well as resources for parenting, support, and stress management.
From a physical therapy standpoint, I wanted to understand her activity levels and how I could modify what she was currently doing to make it as safe and attainable as possible.
From an osteopathic medicine perspective, the first priority was to take a comprehensive history of Charlotte through a conversation with her mother. with the goal to understand deeper of like her overall health. And in that discussion, it became clear that her parents were frustrated with all the previous care that they had received.
From a physician assistant student perspective, my goal was to better understand Charlotte's current symptoms and her asthma triggers, and to simplify her medication regimen to relieve some of the stress that her parents shared with us.
From an occupational therapy student perspective, we're here to provide client-centered care to benefit the overall mental and physical well-being through occupation and to have Charlotte live a purposeful and meaningful life. Here's some key takeaways. The main one is always consider the patient as a whole.
And to have confidence in yourself as a healthcare professional and your role in the team.
Client-centered care is vital.
And lastly, we don't have much time, so we must go slow. We would like to thank the faculty and our student facilitator who worked with us, and thank you all for being here today.
Hi, everyone, and welcome to A Breathtaking Experience, an interdisciplinary approach to pediatric asthma management in rural Maine. We are IPTI Team 6. I'm Mackenzie in Dental. We also have presenting Lindsay Social Work, Carrie Physical Therapy, Jennifer Dietetics, Meredith Osteopathic Medicine, and Mallory Public Health. We'd also like to thank our team facilitators, Courtney Jeffers and Kelly Fox.
The interprofessional team immersion brought us as individuals from different professional backgrounds together as a team to improve patient care. In this project, working as a team helped us support a young patient dealing with severe asthma triggered by allergies and other challenges. By collaborating closely and using patient-centered and patient-inclusive strategies, we were able to look at the full picture, addressing not only medical needs, but also the environmental factors affecting the family's life. This approach made sure the family got practical health resources and guidance that fit their lifestyle to ultimately help support our clients' urgent needs.
The case was based on 6-year-old Charlotte, who has allergen-induced asthma and whose family recently moved to rural Maine. Since the move, she has been experiencing increased asthma attacks, poor engagement in school, and frequent hospitalizations. Due to the asthma attacks becoming more severe and frequent, the family was recommended Charlotte be provided a pediatric team. Our main concern is providing accessible, quality care to Charlotte and her family while living in a rural community.
We spent the first session trying to get to know our patient, Mrs. Soto, and introducing our team. The team members who were present in the first session were a social worker, physician, and pharmacist. The second session, we were able to discuss as a team and narrow our focus, specifically to medication concerns, oral health, physical health, and diet. The appropriate team members were sent in to address these concerns.
In this session, our priorities were to introduce ourselves to Mr. Soto and check how the family has been doing since we last spoke. In part 1, a public health professional and social worker were present to ask questions and offer resources. In part 2, we reviewed diet management, oral health, physical health, and offered additional resources. This session had a dentist, pharmacist, physician, dietitian, and physical therapist present. Working together, we were able to offer effective interventions that met the family's immediate needs and concerns.
During interdisciplinary team collaboration, various health professionals draw on each other's unique expertise to achieve the best possible outcomes for the patient. This approach transcends having several experts involved with different opinions. True collaboration involves constructive communication and teamwork, which can be an effective method of evaluating and treating patients to address patients holistically. The future of healthcare, collaborative, motivational interviewing is useful to provoke positive changes in the outcome of a patient's overall health. Thanks.
Hello, everyone, and welcome to Integrative Care Approaches for Dental Rehabilitation in a Patient with Complex Medical and Social Needs. We are PHIT Group 2. Our patient is a 35-year-old female complaining of chronic tooth pain with poor dentition and is looking to have dentures made. She is highly motivated to work with her care team. She has had these symptoms for the past 5 years and states that she has been unable to maintain her oral health. She does have insurance through Maine Care and is currently in between jobs, but has transportation provided by her caseworker. The patient has a history of methamphetamine use, anxiety, depression, anorexia nervosa, and psoriasis. She has no known drug allergies, lives in a camper in a rural area with her fiance, and she's only able to access clean water from her neighbors. The patient reports use of nicotine vape and used to drink socially but has stopped since she's trying to recover from methamphetamine use disorder.
For our patient's social determinants of health, she comes from a low income and has poor financial stability due to being between jobs. She currently is also lower education. She also struggles with food insecurity due to her area and low income background. Socially, she's more isolated in her area and has stigma due to her substance use.
So the way we organized a lot of this is looking at the factors first that she has access to through use of this map. So she has some social support from her boyfriend. She has the rideshare from her caseworker, and she's getting water from her neighbor, as well as going to the methadone clinic. What we're focusing on as far as interventions are the green resources you can see here, which are what she's currently not accessing. So Washington County, where she lives, has a strong recovery network that includes a career center, food pantry, mental health center, which can help alleviate some of the issues that she's dealing with if you follow up. And we also are going to be looking into telehealth for some health literacy and dental hygiene, as well as access to care.
For her multidisciplinary intervention, this collaborative multidisciplinary intervention plan ensures a holistic approach to the patient's dental health, mental health, substance use, and overall well-being. The caseworker acts as the coordinator, linking the dental professional, primary care provider, and fiance to create a comprehensive support system for the patient by addressing the patient's immediate pain, oral health needs, and underlying issues. The intervention aims to improve both her physical, emotional health and fostering long-term recovery and stability. Any questions?
Our patient-centered framework is regarding a fictional case study about Miss Pond and rheumatoid arthritis. Thank you for listening. To start, a theory-driven review on gender bias in pain care showed that women more often must struggle for their pain to be seen as legitimate in the context of clinical encounters, and their pain is more psychologized, mistrusted, and judged as unreliable depending on their appearance. A brief synopsis of this case study is that Marcia Pond is a 48-year-old female that presents to her primary care physician with a chief complaint of a 5-day history of bilateral pain, stiffness, and swelling in the joints of her hands and feet that is affecting her activities of daily living. She has had 4 visits in the last 2 years to this medical office for similar complaints. She has trialed over-the-counter analgesics, heat and ice therapy, and venlafaxine with limited effect. She reports the pain seems to get worse when she is experiencing a lot of stress. This is our case framework. The red are risk factors and the green are protective factors. The key points of this framework is that she is a recently divorced single mother to a teenage son. Her son just came out as gay and is experiencing bullying at school. She does not receive child support payments and is experiencing financial instability. She is a full-time registered nurse and is having difficulty completing tasks. She has aging parents that are somewhat dependent on her. She has some transportation barriers due to being the primary driver of her household, and pain is limiting her driving ability. She has a medical history of obesity, hypertension, hyperlipidemia, generalized anxiety disorder, excessive alcohol consumption, and a 20-pack year history. Our suggested interventions is the priority is to get Ms. Pond diagnosed and her pain managed. We would order labs that, if elevated, may confirm a diagnosis of rheumatoid arthritis, and her PCP can potentially prescribe prednisone and or methotrexate, as well as refer her to rheumatology for future management. We would also like to include a referral to psychiatry to help manage patient ongoing stress, generalized anxiety disorder, and any additional mental health concerns that can arise from living with chronic pain. These specialty appointments could potentially be telehealth to address transportation barriers. For social resources, we outline several possible avenues for Ms. Pond to receive socioeconomic support. Financially, this includes FMLA, Single Mothers Grants, and Office for Family Independence through Maine Health and Human Services. For transportation, she can contact RTP. For substance challenges, the Portland Recovery Community Center and Maine Quit Link can provide further support. Out Maine provides parent resources in supporting LGBTQ children in regards to her son coming out. The key takeaways that we take away from this case study are that we must always consider the social determinants of health. We must always use evidence-based practice and avoid attaching bias or stigma when treating our patients. Additionally, it's important to remember that every healthcare professional offers unique expertise in improving a patient's well-being. It's crucial to work collaboratively and encourage interdisciplinary discussion. And lastly, community engagement is essential since healthcare providers have a unique voice and authority in being able to advocate for the community. Thank you for listening.
That was fantastic. So, questions for our presenters. I know I have one right off the bat on that first slide in talking about the bias that is in the health community about women and pain. And I would love to hear more from this team about what you learned, because that is very significant. And I don't know whether you chose to develop the case around that, but it just blew me away, that first slide. So love to hear from you.
So I think we had initially based this off this case we developed around a real patient that struggled to get her rheumatoid arthritis diagnosed, even though she had a family history of it. And the reason that they kind of withheld her diagnosis was that her labs weren't coming back as positive. And so despite all of this other evidence that she had in terms of like her general clinical presentation, the family history, and her believing that she had rheumatoid arthritis, they told her that it was all in her head and she has something else and they'll figure it out. But they just kept putting it off and making her suffer through these symptoms. And so I think something that we have to do is, yes, we have to listen to lab values and diagnostic tests, but we also have to listen to our patients and make sure that we are hearing them and advocating for them at the same time.
Can I add on to this as well? Yes, I know we mentioned in our presentation that the bias is specifically for women in diagnosing chronic pain, but I also want to highlight the stereotypes that are imposed on men. Usually when men grow up, they're told to kind of bear the pain, and there's always this stigma on going to the doctor for the pain that you're experiencing. And so this can hinder diagnosis and even reaching or going to the doctor for their symptoms.
So there are stereotypes or biases in either direction. Yeah. Yeah. I think that also just getting to the doctor or the PA or whoever is treating pain, pain is such an amorphous thing because it's very hard to measure. So proving it is very difficult. So what you said on B, is that right? Is really about listening to the patient and being very patient-centered. I don't want to monopolize. Who else has questions for this team? Well, I guess I'll do it the other way around. Does the team want to mention anything that wasn't that you weren't able to put on that very brief presentation, which was done very well, by the way? Is there anything you'd like to share with the audience? What did you learn? How did you capitalize on each other's strengths and knowledge?
I think something that I learned is the importance of community health workers or people who can advocate for patients in and out of the medical clinic. I know we didn't put this in our slides, but as you saw, there were a lot of interventions that could potentially improve our patient's condition. And sometimes as providers, we don't think about their receptiveness or our patient's willingness even and ability to actually go to those resources. And so having an advocate outside of just us as providers would be great. And this was something that was mentioned by Dr. Linkow and Dr. Lee, and encouraged us to think about as well.
Yeah, and just to add on to that, I think something that was cool was that Ritz, Fiona, and I are 2 comm students and a nursing student, so we didn't have a lot of outside support in terms of what resources we have in the community. And so being able to take that on ourselves and do the research to help find out that information, I think is really important as future healthcare workers to just also know how to provide for your patients outside of the hospital.
Are we ready to go to our last one? Thank you.
Miss Roberts, a 33-year-old from Maine with a history of recurrent binge drinking and intermittent sobriety since 2018, presented with acute alcohol intoxication, mild delirium, and a chin laceration from a fall, exacerbated by increased drinking after her father's sudden death. Her comorbidities include a BMI of 29.55, which classifies her as overweight, and she has pernicious anemia. Her medical history includes SVT, anxiety, and depression. Ms. Roberts reports a low nutrition diet, poor sleep, recreational marijuana use for depression, recent suicidal ideation, occasional unprotected sex, and lack of therapy or prescribed treatment for her anxiety and depression. Ms. Roberts, an educated mother of 3 with minimal contact since 2020, lost her high-level job due to drinking, faces potential food and housing insecurity, and has a history of 2 OUIs and a year on parole.
Ms. Roberts has struggled with alcohol use disorder for 6 years, facing
complex personal and social challenges. On the individual level, she started drinking at 16, which has contributed to ongoing issues like job instability and imminent health insurance loss. Her binge drinking pattern has led to emergency room visits, and she contends with health issues like anxiety, depression, and SVT. Poor dietary habits and erratic sleep worsen her condition, and on the societal and familial level, she feels isolated, lacking familial support. COVID-19 shutdowns in 2020 limited her access to treatment, and the sudden loss of her father in 2022 severely impacted her mental health. Despite these hurdles, Ms. Roberts remains committed to overcoming her alcohol use disorder. On the individual level, her educational background highlights her capacity for growth, and she has actively pursued treatment, participating in multiple programs and remaining sober for weeks at a time.
Treatment plan and possible interventions. Ms. Roberts underwent further evaluation for alcohol use disorder with a behavioral health nurse practitioner. Her audit score was 38 out of 40, indicating severe AUD. With previous attempts at recovery through outpatient services, Ms. Roberts will attend a treatment facility with community housing for 3 to 5 months. This will include a PHP, IOP, and optional sober living program. Ms. Roberts has been provided with a recovery coach and many in-person or online options for daily recovery meetings until her intake at treatment in 2 weeks. Ms. Roberts will receive a case manager, licensed alcohol drug counselor, psychiatrist, and access to a full medical staff, where they will also be going over her previous blood work and following up as necessary.
To better address Ms. Roberts' comorbid symptoms of anxiety and depression, future considerations include osteopathic manipulative treatment, also known as OMT, to address the 5 models of osteopathic principles and philosophy, as well as art therapy, mindfulness practices, social support groups, and cognitive behavioral therapy. Thank you.
We're excited to discuss the management of acute chest syndrome in an asylum seeker using an interprofessional approach to care. My name is Andrea Mesa.
My name is Yvonne Chiti.
And I'm Marissa Canty. And today we will briefly run through an overview of our patient's case, discuss the factors that impact our patient's health conditions, and triage our care to best support our patient through a patient-centered framework. So Noah Charles is a 9-year-old male with a past medical history of sickle cell anemia and asthma who presented to the emergency department via ambulance transport with an acute onset of shortness of breath, chest pain, and extremity pain. The patient's mother stated that the patient the previous night had a fever that was managed with acetaminophen. The patient did awake from his sleep, gasping for air and wheezing, prompting the patient's mother to activate EMS. The patient's mother assisted the boy with the prescribed inhaler, which expired 2 years ago with no relief. Noah was diagnosed with sickle cell anemia at birth in his home country of Denmark. The patient had established care with the hematologist at the age of 2 and was started on hydroxyurea. The patient was also diagnosed with asthma at the age of 3, managed with an albuterol inhaler as needed. Due to dangers in his home country, the patient has not received comprehensive maintenance over the past 3 years and has since exhausted his hydroxyurea prescription.
Noah's sickle cell anemia is influenced by both negative and positive risk factors. Negative factors include limited healthcare access due to financial constraints, crowded living conditions in a New York City hotel, exposure to pollutants, poor diet from relying on the New York City food bank, and emotional stress from relocation. Inadequate prior care in Denmark and an unknown paternal family history further complicate his condition. Addressing modifiable factors like diet, weight, housing, and insurance access is crucial to reducing risks like acute chest syndrome. On a positive note, Noah has family support, access to public transportation, the New York City food bank, and free school meals. By leveraging these strengths and addressing negative factors, an interprofessional team can better help Noah manage his condition.
In addition to stabilizing the patient's condition, a patient-centered treatment plan addresses health-modifying factors through various means. We can assist with Medicaid application to ensure access to prescription healthcare, improve nutrition via services like Evolve New York City, and Raising Health, and referring the patient to the Migrant Relocation Assistance Program to help move to areas with fewer environmental allergens. New York City Mobile Health Services can provide primary care, and a map of local water refilling stations can ensure access to safe drinking water. Lastly, we can recommend the Asylum Seeker Research Navigation Center for confidential research assistance. Thank you.
Hi everyone, I'm Hannah Brannigan, a Master of Science in Applied Nutrition student at the University of New England.
And I'm Melody Woodrow, a Master's of Social Work student also at University of New England.
And today we'll be sharing our experience with developing professional and empathetic skills in telehealth during the Interprofessional Team Immersion, or IPTE.
First, a huge thank you to our facilitators and teammates for their guidance during IPTE.
And of course, a huge thank you to our wonderful actors for their time and talent. They've really brought our case to life. But before we dive in, we have a question. Have you ever come up with a plan only to throw it completely out the window?
That's what happened to us. We had a great plan, but as soon as we met our patients, we realized our original plan was not what our patient needed. So we abandoned ship and pivoted. First, a bit about our patient. Charlotte Soto is 6 years old and was diagnosed with allergen-induced asthma. Her parents were concerned about her medications and recent asthma flare-ups.
So our initial plan was to empower Charlotte's parents with tips for medication management, dental hygiene, and nutrition education.
But once we spoke to Charlotte's mom, we realized the family needed more than medical interventions. She needed a prescription of empathy and support.
So what actually happened? We learned the Sotos felt judged by their new community and they were facing financial hardship. Mrs. Soto was also having a complicated pregnancy, so Mr. Soto had to step in as a caregiver, a new role to him.
After realizing the Soto family was facing more social determinants of health than we expected, we used more soft skills than just our technical skills.
So, how are we able to shift gears as a group?
It starts with building a strong foundation.
Before we even met our patient, we got to know each other, share our expectations for the case, and came up with the cutest team name, Wellness Wombats. And it might sound like a small thing, but it really helped us get to know each other.
We also leaned on each other's expertise. We learned to admit that we don't know everything, and that's okay. So, we referred our patient to each other, which allowed us to deliver quick wraparound care.
Next, we learned listening is communicating. At first, we thought communication meant sharing medical information, but we quickly learned communication actually runs deeper.
To make sure that our patients felt truly cared for, we used motivational interviewing. This helped us listen to what they needed instead of pushing what we thought they needed. When we realized the Sotos needed more than direct medical intervention, we regrouped, shared feedback, and adjusted our approach.
Since we had built a great foundation before the case, it was easy to have open and honest communication about how we could best support the Sotos. Teamwork really does make the dream work. Thank you.
Hi, this is Group 7 with our patient-centered framework. Our case is Miss Sylvie Smith, a white non-Hispanic 22-year-old female, 8 months postpartum with concerns of menorrhagia and fatigue. Her period returned at 6 months postpartum, and she is exclusively breastfeeding her child. The period pains are pretty debilitating and quite heavy, and she's also experiencing food insecurity, depression, and urinary incontinence when she laughs. To note, Sophie is nutrient deficient due to food insecurity, and she has concerns about the cost of medical care. Sophie's physical exam and blood work are showing signs of anemia. Looking to additional individual and lifestyle factors, blue bold are the negative or depleting factors, and the darker ones are positive or neutral. So Sophie is homeless, she has heavy caffeine consumption, and brittle teeth after pregnancy. Sophie was formerly enrolled in the foster care system and was emancipated from her family at age 16. She is not currently enrolled in SNAP or WIC, but she does have Maine care for health insurance. Sophie also does not have childcare. The environment component, Sophie has access to medical care, mental health care, and limited access to dental.
How to proceed, this is our ranking order. We're focusing on identifying categories of need in each area, delegating interprofessional team roles between social work, medical, and dental, For social work, our plan is to establish resources and foundation for care options to address the food insecurity, housing, and insurance through working to find housing options using her Maine Care insurance, assisting with registering for SNAP and WIC for her food insecurity, and referring her to therapy services. For her medical care, to focus on the menorrhagia and depression, based on her blood work, she has iron deficiency anemia, and so we will be incorporating an iron supplement, 65 milligram daily prescription, rechecking her blood work in 2 months at a follow-up appointment with us. We have a nutrition plan that will be on the next slide. We will be continuing ibuprofen as needed for the period pain, but not with the iron supplement. Referral to pelvic floor physical therapy to improve pelvic floor strength and decrease pain symptoms, as well as urinary incontinence, and referral to psych with a social worker. For nutrition, she'll be focusing on increasing iron, beginning a multivitamin, and improving her vitamin C intake within her financial and medical needs now that she has food stamps. And with dental, we're going to establish care and a plan for her brittle teeth long term. Thank you so much. Any questions?
Hi, we are 2 members from an interprofessional team here to highlight the value of whole person care through cross-discipline collaboration. My name is Renata. I'm a dietetics student, and this is Shelby, an allopathic medicine student.
So our case study through this project was looking at a 6-year-old with pediatric asthma exacerbations in the context of a family that is new to a rural area, does not have health insurance, is expecting a 3rd child, and feels a bit confused and frustrated over the treatment regimen. Quickly, we discovered that the chief complaint of asthma could only be understood and addressed within this broader context that the family was facing. They were overwhelmed and seeking concrete, actionable steps. We noticed that when we tried to address dietary counseling and nutrition, the patient's father was a bit resistant to this. And while this was understandable, we left us wondering how can nutrition education and dietary counseling be delivered effectively within a patient-centered interprofessional team.
So at the patient level, it's important to know that the American Academy of Pediatrics report that 1 in 4 parents have low health literacy, which leads to poor health outcomes in children and specifically impacts poor knowledge about asthma and how to manage it.
A meta-analysis in 2022 highlighted 7 core counseling strategies for providers to use. Among them were connecting to motivation, showing empathy, and tailoring the counseling to the patient and the family in particular. And not only was this relevant to our case, but it was resonating with a lot of the principles that we've learned through IPT.
And in order to provide a whole person care approach, providers also need that institutional support. So there's a higher likelihood of empathic connection between patients and providers if the provider experiences trust, respect, and belonging on the back end. And lastly, structures upstream are needed to support that whole person care. So there's a high value opportunity to enhance nutrition education at the academic and curricular level so that teams are set up to collaborate effectively. In the case of our patient, we believe that the parents may have been more receptive to the nutrition content had it been more integrated into our recommendations rather than introduced as an additional overwhelming topic for them.
So in conclusion, when we're looking at the efficacy of these dietary interventions, it's important to look at these 4 interrelated levels, including the patient, the provider, the team and institutional support, and also upstream considerations.
Thank you all. We're available for a question and answer now.
Hey, thank you so much to Team 2, the Koala Care Bears. If you're here, if you can identify yourselves.
Hi, I'm Renata. Happy to be here.
Hi, Renata.
Yeah, I'm Shelby.
Hi, Shelby. Does anyone have any questions for the Koala Care Bears?
Yeah, hi guys. Really great job on your presentation. And I feel like I can relate a lot because obviously we did the same case as well. But I think there were still some like slight differences in how our patients reacted, which is really funny as well, and kind of cool to see those differences and similarities. So in your presentation, you mentioned that maybe the parents were feeling a little bit overwhelmed by the approach that you initially had. So how do you feel like your approach changed as you were working with the SODOs?
Thanks. I think, yeah, we chose to zoom in on the nutrition education piece because that's what kind of felt like the biggest challenge and what kind of had to shift throughout the different sessions with the family. And so we were kind of, I guess, thrown off a little bit initially by how like almost reactive the father was to some nutrition information. It was a very quick stop of like, can I call you later? Like that info is too much. You've already listed out some ideas because we were approaching more from a public health and like social determinant of health perspective. So when I, as the dietitian, joined in the room and then was like, okay, and now we have additional info about food and tried to approach it that way, it felt like too much. So I think our shift and what we wanted to really reflect on in this presentation in the showcase was just how could that be more integrated to the initial conversations. So it's more like our reflection after the fact than to your point of like maybe what we changed along the way. Do you have anything to add, Shelby?
Yeah, I would agree with all of that. I think one thing that we ended up like implementing, maybe without knowing it, was just tailoring our care to the family and their different priorities, and not trying to like force our agenda on them, but really meeting the family where they were. So yeah, I think that was like the big lesson learned. And it was really interesting because we had like the father and the mother who also had their own differences and their own different priorities. So trying to kind of address both of them at the same time, and that was kind of also a challenge that surfaced with the dietary counseling as well.
Yeah, it was definitely, I'll just add, really interesting to navigate, like, because it was a red flag. Like our actor that is the mom was listing like our child is on these 10 supplements, and then we have all these, then she's not eating at school. Like there was big nutritional red flags related, but if they weren't ready for that information, then like as Shelby said, we can't force it on them. And something that came up in our feedback with the actors, which was a really important piece, I think, of the whole experience, was being able to have that conversation with the actors like off stage, like out of character. And something that stuck with me was they said just to remember leaving the patient like one bit better than the last interaction, like is something you can walk away with feeling proud of and sort of as a win.
I have a question. So just from like my experience in your shoes, I know how it felt for me when the dad was super abrupt. And I'm curious how it felt for each of you guys when you were in that experience, and kind of how you got through it.
I think like one strategy that I was able to use was just stating clearly and directly my empathetic response to him. Like, I don't know if you guys have learned like five statements, but that's something they teach us. And just, I was kind of like almost disarmed by how effective it was for the father to just feel listened to and heard and acknowledged, and it kind of just immediately like turned down the temperature and gave us a bit more room to talk about the things that we felt we wanted to talk about, needed to talk about, while still respecting the patient. But I know, Renata, I want to give you a chance also to respond.
Yeah, I agree. I was going to say, like, even though we could understand that there was like tension or maybe a hard moment, it didn't feel uncomfortable, sort of surprisingly. Like it was just so well managed in the room. Maybe that's also because I wasn't the lead of the conversation that I didn't feel the discomfort like boil up. But it just, I think being able to hold the space, and we really came from a place of understanding. So we weren't, I think the patient or the parent could also see that, like, and feel that. So they didn't then have to be defensive or have to prove their point because we were hearing them really where they were coming from.
Just a final thought for reflection. It was fortunate that the Sotos had Renata on the team, right, who's a dietitian, and so she could address the nutrition issues. But realistically, oftentimes you may not have a dietitian on your team. So what would you do then in that situation? Just something to think about for the future. Okay, great job, Renata.
1000%. It more integrated. Thank you.
Great job, Shelby.
Hi, this is Building Trust, Multidisciplinary Approach to Patient Care, and this is a collaboration of students from various programs at the University of New England through the IPE-PHIT class this past fall 2024. We come to you with Lynn, who's a 31-year-old Vietnamese-American female with intermittent headaches the past 2 years that have increased in intensity recently. She has general distrust towards doctors, partially because she observed her sister's kidney treatments and fatal illness when her sister was just 3 years old, and also because she has generally felt invalidated by doctors in the past. This has made her more reluctant to seek medical attention, including for these headaches. She has a history of PCOS, which comes with irregular menstrual cycles. She has a mostly sedentary lifestyle. She's a busy mom who's also a full-time administrator. And she does participate in a weekly golf club that allows her both exercise and social interactions, but that's just once a week. She eats a well-balanced diet, but does consume up to 5 cups of coffee every day, as well as alcoholic drinks throughout the week. She is married and engages in couples counseling and also has her mother living nearby who helps her with childcare. She is well educated with a master's degree in higher education. Other risk factors include prehypertension, self-reported depression and anxiety, and it is of note that she has been prescribed metformin for her PCOS. She does not participate in individual counseling and does not socialize as often as she would like. She has no family history of CVD, heart attack, or cancer, and has had significant increase in family income over the last 4 years, and this has also allowed her to have a very stable health, vision, and dental insurance. After getting to know Lynn and thinking about her various risk factors, the first thing we would do is set her up with a PCP who she feels comfortable with and can start to establish consistent multidisciplinary care. It would be vital to inform that physician about Lynn's previous negative experiences so she could start to build a relationship built on trust and with a healthy rapport. It is possible that Lynn is suffering from somatic dysfunction of the temporalis or another muscle in the head, and for this we would recommend osteopathic manipulative treatment. It is also possible that her self-reported anxiety and depression could be exacerbating these headaches. For this, there are a couple of options. We would probably recommend that she consider online support groups, local in-person social groups, and counseling, so individual counseling in addition to her couples counseling. It would be important for her to be tracking and journaling her headaches to observe patterns and other contextual factors that precede her headaches to help have a better understanding of where these might be coming from. One other possible explanation could be temporomandibular disorder, and this could be mitigated with exercises or night guard or some other type of dental intervention. It would be important to get her in touch with a dentist for that. We might recommend alcohol and diet counseling, as her alcohol consumption and coffee consumption could be contributing to her headaches. And we might also prescribe sumatriptan for acute attacks and follow up with a psychiatrist for a possible prescription for venlafaxine for depression and migraine prophylaxis. Thank you so much, and we look forward to your questions and or comments.
Team 1, thank you. If you are present, can you please identify yourself?
Hi, my name is Becca.
Hi, Becca.
Hi, Amiga.
Amiga.
Hi, I'm Erin.
Hi, Erin.
And I'm Simona.
Hi, Simona. Great presentation. Does anyone have questions for this team? Well,
I have a question. Can I ask a question, Kit?
Sure. Go ahead, Shelley.
So, again, great work. I mean, just wonderful watching all of these. There are a lot of things you want this patient to do, a list of things for her, all good suggestions. Did you think about where she would start? You know, how you transition her, her to begin to.
Yes, but I could. Yeah, I think we definitely want to start her with her PCP and just build that relationship first. That would be first and foremost, get her to hopefully so she can experience just what a healthy relationship with a medical provider could be like, and begin with that. Definitely not all these things would be helpful for her, or could be helpful, but maybe not. Definitely not doable for her to do all of these things. Absolutely. I think it would be up to her PCP to kind of help guide her through these options and helping to bring her to the right professionals based on what she's learning now with this more in-depth relationship she could be forming with her PCP.
To kind of build off of Becca, I think also what we were trying to go at is to see what she would be comfortable with. So whether it's like going to an OMM specialist or going to a dentist or trying out medications, kind of seeing what, in conjunction with the PCP, seeing what she's comfortable with and is actually willing to try. So I guess giving her those options is also like one way we thought about approaching her care.
Well, I have one. Earlier, a team mentioned that they didn't have a lot of conflict because originally it was 4-member team, 2 dropped out, and it left 2 members. And they got along really well, but they stated that they wish there was actually more teams and to have like conflict so that they can kind of learn how to work through that conflict. Did you have any such moments within your team? And how did you work through them?
I wouldn't say we had any conflicts per se. Like when we did start like deciding on a case, we kind of sat down together, all 4 of us kind of were able to meet, and we kind of looked at like different topics, like different directions we could take the case in. And then we kind of gave like a different aspect of the case to people who were like strong and like people whose backgrounds fell with it. So like me and Simona being from COM, we took a lot of like the HPI, the medical stuff, the medications, and then Becca and Erin took like the social factors. So looking at the diet, the nutrition, the support groups, and all the other factors that could go into her care.
Yeah, I think we all like sprinkled our own little profession into the case as well. There weren't like disagreements, but we were like, okay, maybe we're going too off into the com track. Let's take it a step back and look at it from, like the dental perspective at the end. I was like, oh, I would have never came up with that. Just little things like that. So no arguments, but healthy discussions.
Yeah, I will just add, there was a lot of talking through our thought processes and yeah, just getting in depth with our personal knowledge of the topics or what our expertise is, but no disagreement.
Yeah, I think more people offers you the opportunity just to have more input, whether that's from anyone's specific background or just generally from their own life. This person is a woman, and she's part of why we chose this case is because something that women can deal with a lot in medical settings is just not being heard or listened to or kind of being brushed aside. And so I think this was also an opportunity for us just to bring not just our personal experiences, hopefully not in a biased way, but just having more people who can bounce off ideas that maybe we've experienced or have learned about in our own individual programs.
Well, I will admit I'm a type A personality. And so sometimes I want to take control. And I think sometimes when you're working in a health professional team, it's very easy for someone to just take control of everything. But the fact that you all recognize that other professions had valid viewpoints and you transitioned and asked for more collaboration, that's amazing. That's a skill that is very, very difficult to attain. So kudos to your group for being able to recognize the importance of all your other teammates.
And if I can add to that, I'd really be curious about, I agree with you 100%. Great work. Maybe you could say one thing you learned from each other. Just one thing that you didn't know before. I know, Simona, you mentioned you wouldn't have thought of the dental aspect of it, right? So what other thing might you have taken away?
I had personally never heard of any of the osteopathic methods for dealing with a headache. I've literally never once heard any of those words before. And that was vital for me as a future dentist who might also be treating something very similar with a very different method to understand that that is an option for someone where my method might not be working for them.
That's awesome. That's great.
And then I would say, I know a few times the ON students brought up like, oh, maybe we can't do that medication because of contraindications. And so just having that knowledge, like, oh, wait, we have to also account for this. That was really helpful.
Thank you.
And just adding on, like as a first year, like we don't have so much exposure. So being able to learn from like the second year Simona and then like also like Becca and Erin, just like how to connect like all the different things like the dentistry and like nutrition and then like also the contraindications and everything with the medications was really cool to put together with the case.
Oh, I guess I learned the dental thing, but I guess another thing I learned, it wasn't specifically from my group, but from working with a pharmacy student, I learned about Medscape and like the drug-drug interaction. So that's kind of like one way that I was like, oh, like let's make sure that, all of these or like whatever we're recommending to her isn't a contraindication. Because while it might seem good in the moment, maybe down the line she'll have an adverse effect or not feel good, and then it'll just hinder that relationship that we're trying to build for our patient.
Thank you all so much. Great job, Fit Team 1. It's 12:58, so we're coming to a close. I would like to thank all the students that participated in the IPD and FIT programs. You all did excellent work. Thank you so much to the faculty and student facilitators who helped out. Thank you so much to Shelley Cohen Conrad for the great programs that you have done and created for CAIEP. Thank you to Chris Hall and Michelle Cote for their administrative help. And please scan the QR code to complete the attendance form. Thank you so much for coming today, and we hope you enjoyed this session. Have a good day.